Hello friends, let us now learn some important points about the antibacterials. There are two types of antibacterials. One, we have bactericidal agents. Second, we have bacteriostatic agents. Bactericidal agents will kill the bacteria and they cause irreversible killing of bacteria. These bactericidal agents also are cell wall inhibitors. These include then bacteriostatic agents, they will arrest the growth and replication, they will inhibit the DNA replication and DNA protein synthesis. So these cell wall inhibitors include beta lactams and vancomycin. These bactericidal agents are also aminoglycosides which will inhibit the protein synthesis. These bacteriostatic agents include tetracyclines. So if you see, this is the mechanism of action chart. So para-aminobenzoic acid combines with dihydropteridine to form, in the presence of folic acid synthase, it forms dihydrofolic acid. This forms tetrahydrofolic acid which will help in DNA synthesis. So this DNA synthesis, it gets converted to, the next after DNA synthesis, the DNA gets converted to RNA. That is, RNA synthesis occurs in the presence of DNA dependent RNA polymerase. Now RNA is formed. This RNA which is formed is used in protein synthesis. Now proteins are synthesized with the help of the ribosomes and the polyprotein chain. So this is the main thing that is important. Now if we see the drugs which act, sulphonamides will inhibit the dihydrofolate reductase, whereas trimethoprim will inhibit the conversion of dihydrofolate reductase to tetrahydrofolate reductase. Fluoroquinolones inhibit the DNA gyrase. Then the drug rifampicin will inhibit the DNA dependent RNA polymerase. It inhibits DNA dependent RNA polymerase. Then there are 50S inhibitors and 30S inhibitors which inhibit protein synthesis. 30S inhibitors include aminoglycosides and tetracyclines. 50S inhibitors include macrolides and chloramphenicol. So these are the important drugs, and we also have other drugs like we have cell membrane inhibitors are also present. So we have first cell wall inhibitors, then we have cell membrane inhibitors. These cell membrane inhibitors will displace the calcium and magnesium from the cell membrane, and this will cause leakage of intracellular content leading to cell death. This will cause leakage of intracellular content leading to cell death. Example is amphotericin B and polymyxin are the cell membrane inhibitors. Now this is important points about antibacterials. Then we have the drug antimetabolites. So in the antimetabolites we have sulphonamides first. So antimetabolites are sulphonamides. The mechanism of action of sulphonamides is para-benzoic acid combines with the pteridine residues and it forms, in the presence of folate synthase, folate synthase and also dihydropteroate synthase, it forms dihydropteroic acid. This dihydropteroic acid, in the presence of this will conjugate with glutamic acid to form dihydrofolic acid. This dihydrofolic acid, in the presence of dihydrofolate reductase, it forms tetrahydrofolic acid. Right? So now the drug sulphonamide will inhibit this folate synthase. So the para-aminobenzoic acid will combine with the sulphonamide and it forms altered folate. Now if you see the drugs, the sulphonamides are divided into three types which are called as short acting, intermediate acting and long acting drugs. Short-acting drugs includes sulfadiazine. Long-acting drugs include sulfamethoxazole. Intermediate acting drug is sulfamethoxazole, whereas long-acting is sulfadoxine. The half-life of sulfadoxine is 7 days, whereas we also have one more long-acting drug which is sulfamethoxazine. Then short-acting drugs include sulfadiazine, sulfacytine, sulfoxazole and sulfamethizole. Whereas intermediate acting include sulfamethoxazole and sulfamoxazole. So these are the important short acting, intermediate acting and long acting drugs. All these are oral drugs. We also have some special purpose or topical drugs. So these include, we have silver sulfadiazine, sulfacetamide and mafenide. So these are actually present in burns. Then we have oral or non-absorbable drugs. So these are used for luminal pathogens. So these include, we have sulfasalazine, olsalazine or also balsalazine. Sulfasalazine, olsalazine and balsalazine, all these are used in inflammatory bowel disease. Then if you see the pharmacokinetics, these drugs are the oral drugs which have rapid absorption. They have rapid absorption, and these drugs are actually metabolized by acetylation. These drugs are not used alone. Always they are given as fixed dose combination along with Cotrimoxazole. And sometimes they are combined with pyrimethamine and they are given together as sulfadoxine pyrimethamine combination. Then the solubility of sulphonamides will also decrease in acidic urine. And this will precipitate the action of the drug and it will cause crystalluria. So in order to prevent this crystalluria, we should do hydration and alkalinization of urine. As I have already said, this sulfadoxine can be combined with pyrimethamine in a fixed dose combination to form sulfadoxine pyrimethamine. Then this sulfadoxine is long acting, as I have already said, with half-life of 7 days, and sulfacytine is shortest acting sulfonamides. Then one more important point here is the pus and tissue extract. Pus and tissue extract contains purines and thiamidins, and it also contains para-aminobenzoic acid. So this will decrease the bacterial requirement of folic acid and it will antagonize the sulfonamide action. It will decrease the bacterial requirement of folic acid and antagonize the sulfonamide action. Then but see, it is decreasing the requirement of folic acid. Will it affect the human cells? No, because human cells you will utilize preformed folic acid from diet. So human cells are not affected with sulfonamide. Then if we see the resistance, these drugs mainly produce increased amounts of para-aminobenzoic acid. So these drugs also produce folate synthase enzyme. They produce folate synthase enzyme with low affinity to sulfonamides. They adopt alternate pathway in folate metabolism. So if we see the side effects, gastrointestinal side effects include, they cause nausea, vomiting, epigastric pain, they cause crystalluria. They actually decrease, this crystalluria is decreased by drinking water. They cause hypersensitivity reactions, especially they cause rash, urticaria and fever. These also cause photosensitivity. Then they also cause side effects like Stevens-Johnson syndrome and exfoliative dermatitis. They cause hepatitis, and hemolysis. This hemolysis is especially seen in acute hemolytic anemia in G6PD deficiency individuals. So sulfonamides are contraindicated in G6PD deficiency individuals. They causes kernicterus. They also cause aplastic anemia, thrombocytopenia, and they also cause granulocytopenia. So these drugs will displace bilirubin from plasma protein binding. Because these will displace bilirubin from plasma protein binding, and these will cause kernicterus. So if we see the uses are here sulfamethoxazole. Sulfamethoxazole combines with trimethoprim, and this combination is used in UTI, respiratory tract infections. It is also used in prostatitis, nocardia. Actually, it is the drug of choice in nocardia, and it is also drug of choice in pneumonia caused by Pneumocystis carinii in HIV patient. This combination is an alternative to ciprofloxacin in typhoid patients, and it is also used in bacillary dysentery. Then we have the next important drug, which is Dapsone. Dapsone is actually a sulfur drug. The drug of choice for Dapsone is Dapsone is the drug of choice for leprosy, and Dapsone is also drug of choice for dermatitis herpetiformis. Then we have one more combination, which is sulfadiazine with pyrimethamine. This sulfadiazine with pyrimethamine is used in the treatment of toxoplasmosis. It is also used in the prophylaxis of Pneumocystis jirovecii pneumonia in AIDS patients. Pneumocystis jirovecii pneumonia in AIDS patients. Then these drugs, sulfonamides, are actually contraindicated in newborn. They are contraindicated in 3rd trimester pregnancy, renal failure patient. They are contraindicated in renal failure patient, and they are also contraindicated in glucose 6-phosphate dehydrogenase deficiency. Then we have cotrimoxazole. This cotrimoxazole has two things. One, it is used in it divides into trimethoprim and sulfamethoxazole. Then first in trimethoprim. In trimethoprim, it has diaminopyrimidine. It is a diaminopyrimidine, whereas sulfamethoxazole is a sulfonamide. Trimethoprim crosses the blood-brain barrier and placenta, whereas sulfamethoxazole has poor entry into the blood-brain barrier. This trimethoprim and sulfamethoxazole are bacteriostatic, and both combined to form sequential blockade, and thus they are bactericidal agents. Trimethoprim is most rapidly absorbed, whereas sulfamethoxazole is slowly absorbed. Trimethoprim has greater volume of distribution, whereas sulfamethoxazole has lesser volume of distribution. Trimethoprim has lower plasma protein bound, whereas sulfamethoxazole has higher plasma protein bound. Now, trimethoprim and sulfamethoxazole are given in the oral dose of 1:5, and in the plasma they are given in the dosage of 1:20. So this trimethoprim sulfamethoxazole mixture, see, this trimethoprim will inhibit this dihydrofolate synthase, right? Now this trimethoprim sulfamethoxazole mixture together, it is contraindicated in pregnancy. It is contraindicated in renal disease because it can cause uremia. It is contraindicated in elderly because it can cause bone marrow toxicity. It is contraindicated in diuretics because it can cause thrombocytopenia. So this is about the drug sulfadoxine and trimethoprim. Thank you for watching.